Okay, sir, we are live. We can begin.
Good afternoon, everyone. Welcome to the Doc Mode series of ISAR on the subject of infertility. We are extremely sorry for yesterday's mishap, and we hope that we will be able to finish the task today. I proudly welcome our today's speaker, Dr. Gautam Khastgir, who is actually an elected member of ISAR Executive Committee. And on top of it, he has been an organizing secretary of ISAR 2018 of West Bengal ISAR. That's a huge task. Okay. Uh, Anyone in Calcutta knows Dr. Gautam Khastgir, but his fame in international countries like Bangladesh is also very well known, and he has his roots in Bangladesh. There is not a one private medical college in Calcutta who doesn't know Dr. Gautam Khastgir. On a personal note, I know him very well as a good friend and very well admirer, and he always thinks about the institute first, then himself. So, Dr. Gautam Khastgir, please, you can start your presentation.
Thank you, Dr. Kedar Gandla. Very good afternoon, ladies and gentlemen. I bring warm greetings from Kolkata, which is still recovering after the COVID pandemic and, of course, the additional catastrophe of Amphan catastrophe we had, cyclone. But we are doing reasonably well. Now, I'm really thankful and proud to share this platform, and I express my sincere gratitude to ISAR, to all the past presidents, particularly Dr. Jaideep Malhotra, whose brainchild is this Doc Mode webinar. And I must congratulate our current president, Dr. Prakash Trivedi, and Secretary, Dr. Kedar Gandla, for taking it forward so nicely, which is keeping us busy during this pandemic and also helping us to learn more, even without attending different conferences. Now, I have been asked to talk on endometriosis and infertility, which is a very favorite topic on mine. And I've been working in this field for the last 30 years since my MD thesis on this topic. Now, endometriosis, all of you know, is an illness which is not that common, but it affects about 6 to 8% of women in their reproductive age group. If you take the infertile population, then the endometriosis is a cause of infertility in about 20 to 25% cases. And if we take all cases of endometriosis, nearly 30 to 50% of these patients suffer from infertility. Now, it's very interesting that many patients of endometriosis, as much as 25%, may present without any symptom at all, or they are diagnosed accidentally. But as soon as we say endometriosis, it comes in our mind, the first thing is the pain, different type of pain, be it dysmenorrhea, dyspareunia, dysuria, dyschezia, or any other type of chronic pain which usually aggravates just before the menstruation. But it is infertility which, with or without pain, which I'm going to cover today. And we need to keep in mind that there have been several advances in the field of infertility in medicine, in surgery, in assisted conception. And the scenario is changing. In the last 10 years, there have been several changes in our belief, in contrast to what we used to do perhaps in 1990s or in the first 10 years of the millennium. Now, endometriosis and infertility, first of all, we need to understand why it happens. What is the etiopathogenesis? Now, there are different theories. Of course, it is divided into several aspects. Let's address one after another. It could be there is gross distortion of the pelvic anatomy, pelvic adhesions, alteration of tubal motility, but largely alteration of the tubo-ovarian relationship. So there is failure of egg pickup or transfer of the egg within the fallopian tube. Now, in many cases, particularly in early endometriosis, what we find that there may not be any structural advanced changes, but just elevated cytokines and several other substances which are adverse to egg and sperm. So they cause sperm phagocytosis. So this toxic environment created by endometriosis is often responsible for infertility in very early stages where you may not see any structural changes either by laparoscopy or ultrasound. If you look at the quality of the oocyte, it has been found that endometriosis patients, when we induce them with medicine, with gonadotropin, the response is poor. Often the quality of the egg is not so good. Eggs are not completely matured. It is said that there may be LH receptor deficiency. The incidence of luteinized unruptured follicle syndrome is actually much higher. And also, the fertilization rates have been said to be lower in earlier studies, but in my talk, I will tell you there have been change in our concept, in our findings in the recent years with the advances in ART. After the ovary, if we look at the endometrium, we find there may be implantation failure due to altered endometrial receptivity. And it has been reported that HOXA10 and 11 gene are not upregulated at the time of implantation. So this is a microscopic, a molecular change which is responsible for failure of conception in endometriosis. Now, coming to the pregnancy, even after conception, there is a higher incidence of miscarriage, maybe due to luteal phase defect, maybe due to poor quality of the embryo. Now, keeping in mind the causes of infertility, we need to think about the treatment. Now, the treatment modalities are of 4 different groups, and I've highlighted them as medical therapy, expectant management, reconstructive surgery, and assisted conception therapy. Now, whenever I'm talking about all treatment modalities in my talk, I'm concentrating on infertility and not for pain. So endometriosis and infertility, now there may or may not be associated pain. The one thing we have to keep in mind very clear that the medical therapy has very little role in infertility. Even if it has some role, it is very indirect. Conventionally, we have used danazol in the past. No one uses danazol now. We can use oral contraceptive pill continuously, GnRH analog. They are all very good in terms of pain relief. Now, for infertility, obviously they're suppressing ovulation. So how can they help in infertility? But it is said if we suppress endometriosis, if we make the environment better after stopping this therapy, the rate of natural conception or ovulation induction pregnancy or ART pregnancy is actually better. But it is still debatable. Recent therapies like Dynogest, anastrozole, cabergoline have all been used. Now, they are again very effective in terms of pain relief. Studies are not supporting any evidence that they help in improving the conception rate in patients with endometriosis. When we are using ovulation induction, we can use clomiphene, we can use letrozole, we can use gonadotropin, just like any other problems, any other etiology of infertility. Now, not necessarily they work very well. Of course, they had its role, provided the other associated factors like tubes, sperm, everything is okay. But the response, as I already said, with ovulation induction is suboptimum in cases of endometriosis. Expectant management, it is said that in early endometriosis, perhaps expectant management has a very limited role in young patients. So if everything is fine, you have found early endometriosis, you can give them little time, 6 months or maximum 1 year. They try on their own. If they cannot conceive, then we can give them other treatment. Now, the natural conception, natural fertility rate with expectant management is something like 5 to 10% per cycle. So if they are not pregnant after 3 or 6 cycles, then definitely we need to do something more positive. As regards reconstructive surgery, it is definitely very helpful in advanced stages of endometriosis, but it can also be done in early stages if a laparoscopy has been done, a diagnostic laparoscopy has been done for any other purpose, or maybe for pelvic pain, it has been picked up. So we can do laser surgery, we can do diathermy surgery, we can do resection, even in early stages, which I'm going to cover. And these can be done, major surgery can be done either by laparoscopy or laparotomy. Mild surgery, the mild endometriosis treatment is always done by laparoscopy. Now, finally, assisted conception therapy is actually the most effective therapy in all stages of endometriosis. So the fecundity or pregnancy rate is highest with assisted conception therapy. So if a patient comes and tells, okay, we want immediate pregnancy, we don't mind the cost, we don't have any prejudice, you can offer assisted conception therapy to anyone at an early stage. But majority of them are a little hesitant because of the cost and because of other prejudice associated with assisted conception. So we usually keep it as a last resort. Now, during my talk, the remaining part of the talk, I'm going to mainly emphasize on surgery and assisted conception therapy, because with my experience, the medical therapy and expectant management, of course, can be given in some limited cases, but for the majority, it is the surgery and assisted conception which can actually give us pregnancy. Now, as regards the management in infertile women, we can have a sort of plan like this. What I show in this slide is we divide our patients into stage 1, 2, 3, and 4. Now, this staging can only be done by laparoscopy, which we are not doing so much nowadays. So if we have done a staging, and you see stage 1 and stage 2, in a young individual, we can do expectant management, followed by ovulation induction, timed intercourse, or you can additionally do IUI. Now, if this early endometriosis is detected without laparoscopy, like you have detected by the clinical symptoms, then still the same treatment can be given. Now, if the patient is elderly, like over the age of 35, we shouldn't waste much time. We should straight away go to ovulation induction with gonadotrophin and IUI. And if it is not successful, then we go for IVF-ET. Stage 3 and stage 4, either we can do a conservative surgery, reconstructive surgery, followed by ovulation induction, timed intercourse, IUI. And if it doesn't work, IVF. But more and more evidence are coming in favor that perhaps IVF should be taken as a first resort rather than going to conservative surgery. If the patient can afford, if the patient agree, then perhaps surgery actually delays the success rate with IVF. Now, the other way we can look at this problem is by the way we are making the diagnosis. So the algorithm says we can detect nowadays clinically, we can detect by ultrasonography. Now, when we detect by ultrasonography, often it's an endometrioma, or we detect by laparoscopy. If we detect it clinically, we can do expectant management, surgery, and IVF. If expectant management doesn't work, we go to surgery. Surgery doesn't work, we go to IVF. Similarly, if it is ultrasonographically endometrioma, we can either do a surgery, as I've said, or we can go to IVF. And with laparoscopy, obviously, we have done the surgery at the time of laparoscopy. So followed by, we can take an expectant management or ovulation induction IUI, or we can go straight away to IVF. Now, if we go into the surgery, let's understand what is the role of surgery in infertility. Now, it is true that without laparoscopy, the diagnosis cannot be done definitely. So that is why laparoscopy plays a very important role in diagnosis and management. But it is true that nowadays, even without laparoscopy, because of the advances in USG, we are actually detecting and treating many cases of endometriosis without laparoscopy. But because of its widespread popularity, there have been many uncontrolled studies, and the potential benefit of laparoscopy is definitely overvalued. Now, we know the likelihood of conception after surgery over the background pregnancy rate is about 10 to 15%. So if The previous background rate was 5%, it will go up to 15 to 20%. If it was 10%, it will go maximum to 25%. Now, that is pregnancy rate per cycle. So the cumulative pregnancy rate definitely is good, but we may have to wait for 6 months or 1 year, not like assisted conception where we can get pregnancy immediately. Therefore, we need to assess the role of surgery before, after, or as an alternative to assisted conception therapy. Now, what are the aims of surgery in endometriosis? We need to excise or fulgurate all the visible endometriotic lesion without damaging any vital structure. If there is endometriosis and the ovaries are damaged, we have to remove the diseased ovary. But the most important thing is restoration of normal pelvic anatomical relationship, especially around fallopian tubes and ovaries, so that after surgery, the chance of conception, natural conception, or with ovulation induction is much higher. But most importantly, we need to keep in mind, so there is prevention of further adhesion following surgery. There have been different techniques using heparinized normal saline or using intraseed, but sometimes it's very difficult to prevent it. But if there is further adhesion, then the whole purpose of surgery is wasted. And that is often the case. Following surgery, if they have a second look laparoscopy, often we see extensive adhesion following surgery. So the question is whether surgery can give long-term benefit for the cure of infertility. If we look at minimal and mild endometriosis, now there is enough scientific data from two well-publicized randomized controlled trials, one Canadian study, another Italian study, which showed that if we do laparoscopic surgery, then the chance of pregnancy is higher than just doing a laparoscopic surgery. And this was shown in Canadian study, cumulative pregnancy rate in about 36 weeks after the surgery, which is roughly about 9 months. It was shown the pregnancy rate is about 36.6% in contrast to 21.9%. So without surgery, nearly 22% conceived, and following surgery, 36%. So of course, difference is there, but not that significant. What we have to keep in mind that we have to treat 12 patients. So 12 patients having laparoscopic surgery will give us only one pregnancy. So many of us are questioning, is it worth doing it? So a patient presenting with the symptoms of endometriosis, whether we should confirm that with laparoscopy and do the surgery, or we get on with other treatment of infertility available. Now, as regards the different treatment available, laparoscopic surgery can be done with the help of laser, with the help of diathermy. It has been published. There is no much difference between the method. Laser is very expensive and not easily available, although there have been few studies showing the laser is better than diathermy. Now, whether to excise or electrocoagulation, excision gives us the option of biopsy and better removal, but the cumulative pregnancy rate is same, and the intervals in surgery is also same whether we do diathermy or coagulation. ASHRAE guideline published in 2013 said that for minimal and mild endometriosis, operative laparoscopy with adhesiolysis along with excision or ablation is actually the treatment of choice rather than diagnostic laparoscopy alone. And it will definitely improve spontaneous pregnancy rate following treatment. However, if we think about complete surgical removal of endometriosis before ART, it is not really essential or beneficial. So if someone is going for ART, a laparoscopic surgery is not essential. When we look at moderate and severe endometriosis, obviously, unlike minimal endometriosis, there is no randomized control trial. There is no meta-analysis because it's unethical to randomize for patients who have bilateral endometrioma or advanced endometriosis. You cannot randomize between surgery and not surgery because many of them would actually require surgery for the relief of pelvic pain. Now, these uncontrolled studies have shown a very high pregnancy rate between 30 to 67%. Now, these studies may have been biased studies because they're uncontrolled studies. So people tend to report those cases where the results are better. What has been found that pregnancy rate may be around 25%, and the number needed to treat is only 4. So it's much better than minimal mild endometriosis. So if you treat 4 patients and one of them conceive, that is pretty good. But what we have to keep in mind, there is a negative correlation between the stage of endometriosis and the pregnancy rate after surgical therapy. So more advanced the endometriosis, lesser is the chance of pregnancy. That is obvious. There is more damage to the reproductive function with endometriosis. So even after surgery, the success is not that good. But what we understand very well, that conservative surgery is better than no treatment. And it has to be done when there is lots of adhesion and if the endometrium is more than 4 centimeter. If we take moderate endometriosis, the cumulative pregnancy rate is better in comparison to the severe. But whatever pregnancy happens, it happens within a year. So if the patient is not pregnant within a year, it is ideal to offer something else and not wait anymore. But what has to be kept in mind very clearly, there is no role of repeat surgery when we are thinking about endometriosis and infertility. I'm not talking about pain. So if we have done a surgery, it didn't work, somebody else has done it, so there is no role of repeating that surgery. Rather, we should offer them assisted conception treatment. Now, ASHRAE guidelines suggested that excision of endometrioma capsule is much better than the drainage and electrocoagulation in terms of spontaneous pregnancy rate. If the endometrioma is more than 4 centimeter, it is only in those cases perhaps we should do before ART, because it will help in the accessibility of the ovary in terms of egg collection, but not improve the pregnancy rate. Now, the surgery for endometrioma has a risk of reduction of ovarian function, and possibly that lady may lose that ovary, more so, as I said, with a history of previous ovarian surgery. So one has to be very careful, particularly when the previous ovarian function, prior ovarian function with AMH and FSH or AMH and AFC is not very good. ASHRAE guideline also suggested there is no role of surgery for deep nodular endometriosis, rectovaginal endometriosis excision for infertility. It may work very well for pain relief. So someone suffering from infertility with deep nodular endometriosis should actually go for ART rather than any form of surgery. Now, if there is associated hydrosalpinx, then we know the treatment removal or occlusion of hydrosalpinx actually improves the pregnancy rate. It will improve the ART outcome. Now, it is interesting that it has been said that those patients who had surgery, 75% of these patients in a particular study, 75% of these patients had actually had multiple failed IVF. And surprisingly, after surgery, apparently 68% of them became pregnant. So some people are giving very good results with surgery and others are not supporting it. So we have to individualize every case and take our own decision. Now, when you have an ovarian endometrioma, we know excision is much better than drainage. What we do a partial cystectomy and ablation rather than removing the whole ovarian cyst to avoid further damage to the ovary. The success rate for surgery to improve fertility is again very limited with endometrioma. Now, Cochrane database has confirmed that if someone has ovarian endometrioma, then 40 laparoscopic surgeries will be needed to get one additional pregnancy. So number needed to treat is 40 in case of ovarian endometrioma over last 12 months. So unlike previous paper which I mentioned, that in advanced endometriosis, number needed to treat is 4. With ovarian endometrioma, it is 40 when we do laparoscopic surgery. Now, what we have to think that endometriosis surgery has a negative impact. Now, this view has come up in last 10 years. So there's a time for paradigm shift. So we need to be more cautious with surgical approach, because now we understand is less is actually more, or less is better. Because actually with the surgery, we are causing more harm than benefit by excising and ablating the endometriosis. So we need to ask these questions. And why we say this? Because we know that when endometriosis surgery has been done, particularly ovarian endometrioma, there is damage to the healthy ovarian tissue because there is absence of cleavage plane with endometriosis cyst. So when we do stripping of the ovary, In the biopsy sample, in 97% cases, we see healthy ovarian tissue with ovarian cyst. And there is a direct relationship between the cyst size and amount of ovarian tissue. So bigger the cyst, greater the ovarian damage. In addition, we do coagulation for hemostasis, which may damage the blood supply. So all these studies have shown that endometriosis surgery is actually damaging the ovary. Now we have two very good way of assessing ovarian reserve. One is AMH and second is antral follicular count. And what has been reported that after ovarian surgery, ovarian volume diminishes, AMH value diminishes. So before endometriosis surgery, AMH value is sometimes same as control, but definitely it is lower after the surgery. Now, if someone has unilateral ovarian endometrioma, now even after surgery, AMH value may be normal because from the other ovary, AMH value will be fine. So antral follicular count may be a better outcome. And again, I say this outcome of repeat surgery is worse because there'll be further loss of ovarian volume and great loss of antral follicular count. So please, please, please don't go for repeat surgery if the patient is presenting with infertility. Now, women with endometrioma definitely have a low baseline AMH even before the surgery. Now, after surgery, it diminishes further, although it has been reported that after 6 months, there is a possibility of recovery. Of course, bilateral endometrioma will have greater negative impact in comparison to unilateral to ovarian reserve and AMH because you are doing double damage with both ovaries. So, in summary, if we think about minimum and mild endometriosis, of course, ablation of endometriotic lesion and adhesiolysis to improve tubo-ovarian anatomy is very effective in infertile women in comparison to just diagnostic laparoscopy alone. But the benefit of laparoscopic treatment is insufficient to recommend laparoscopy for all endometriosis patients solely to increase the likelihood of pregnancy. So someone has having a diagnostic laparoscopy and we have seen endometriosis, okay, fine, we treat. But if someone is not requiring a laparoscopy just because of endometriosis and infertility, we are not going to do laparoscopic treatment. Now, in younger individual, perhaps expectant management and ovulation induction may be the first line of therapy before offering surgery. With moderate and severe endometriosis, what we find that conservative surgery has got more value. So it normalizes the pelvic anatomy, it causes an adhesiolysis, and it definitely enhances fertility. If the endometrioma is more than 4 centimeter, then we would definitely go for surgery, and it is cystectomy rather than drainage and ablation. If the patient is elderly over the age of 35 years, then more aggressive treatment, ovulation induction with gonadotropin, IUI, and IVF should be considered as the first line of therapy and not really go for surgery. Because as I have repeatedly said, surgery causes damage to the ovarian function. So what are the indications of surgery in infertile patient with endometriosis? Definitely, if the patient is not presenting with pain, we can do surgery in moderate to severe endometriosis. If the patient presents with pain, all stages of endometriosis with infertility can have surgery because it's going to give pain relief, which obviously improve sexual function, and it also increases reproductive function. Now, before ART, the role of surgery is very limited. It is only to improve the access for oocyte retrieval, but not definitely improves the outcome of ART. With hydrosalpinx, we should treat before ART, and surgery is only should be limited to those patients who are not going to have ART for any personal or cultural reason. Then by normalizing the anatomy as much as possible, we can give them ovulation induction. So the take-home message also should include that infertility patient with endometriosis may benefit from laparoscopic reconstructive surgery. The need of surgery has to be individualized depending upon the symptom and stage of the disease. Efficacy in minimal and mild endometriosis has been confirmed by randomized control trial and meta-analysis. However, the role of surgery in moderate to severe endometriosis is limited. It cannot be confirmed by RCT and meta-analysis because of ethical reasons, but we must keep in mind that it may be detrimental for some patients. Now, after surgery, let's look at ART. Now, this graph shows a cumulative pregnancy rate of those patients who had controlled ovarian hyperstimulation, ovulation induction with gonadotropin in blue, in red, who straightaway went for IVF, and in green, who had IVF after controlled ovarian hyperstimulation. If you look at the fecundity rate, in blue, you will find 15% in the first cycle, 12% in the second, 8% in the third, and then gradually it declines, and very little improvement after the fifth attempt. So after 4 or 5 cycles of ovulation induction, there aren't much improvement, and the cumulative pregnancy rate is in the range of about 40%. Whereas those women who straightaway went for IVF, in the first cycle, the fecundity rate was 47%, which is much higher than 5 attempts of ovulation induction. And next attempt, 27%. Third cycle, 33%. So the cumulative pregnancy rate is about 75% after 3 attempts. Now, those patients who had ovulation induction didn't get pregnant and they'd had IVF, they also had very good result, maybe slightly less than who went for IVF straight away. So the message is, please, please, please don't waste much time with ovulation induction. If the patient can afford to have IVF, these endometriosis infertile patients should have IVF as the first choice rather than ovulation induction. Those who cannot afford, after 3 or 4 or 5 attempts of ovulation induction, maybe 4 is the standard, with IUI, additional IUI, we can go ahead with IVF. Now, if we take into consideration different stages and look at this success rate separately, then you will find in stage 1 endometriosis, patients with stage 1 endometriosis a fantastic success rate with IVF. So the first cycle, the success rate is about 45%. And after 3 attempts, the success rate is almost 100%. In stage 2, stage 3, and stage 4, also the pregnancy rate after 3 attempts is in the range of about 60%. Whereas those who are having controlled ovarian hyperstimulation with or without IUI, you will see that after 4 attempts, there is hardly any pregnancy. But if you take the one in red, that is the stage 4 endometriosis, only there was little pregnancy some pregnancy in the first attempt is about 10%, but after the first attempt, there wasn't any pregnancy at all. And we are not surprised. So keeping this in mind, we have to really understand why we offer ART for patients with endometriosis and infertility. Those who have minimal and mild endometriosis, of course, we can treat them with ovulation induction with CC, letrozole, and gonadotropin for 6 to 12 cycles. And with IUI, amongst this 4 to 6 to 12 cycles, 4 to 6 cycles can be with IUI. Now, if a patient has endometrioma, small endometrioma, they can also be treated with OI and IUI for 6 to 12 cycles with or without prior laparoscopy. But if they are not successful, then we can go for IVF. Now, those patients who have additional tubal problem, male factor infertility, along with endometriosis, definitely we should go for ART. Or other patients who had different treatments, it didn't work, then definitely we need to give them ART. Now, those patients with moderate to severe disease, ART is the treatment of choice without any medical and surgical therapy. So if you have a patient who doesn't have any pain, advanced ovarian endometriosis, ART can give them maximum result. Those who have pain, they can have surgery followed by ART, but keeping in mind, surgery is going to reduce the chance of success in ART. Now, there are some risks of ART in endometriosis patients. Now, these are, of course, risks, but more theoretical than practical. We need to be careful. It has been said that controlled ovarian stimulation, which is done for ART, are likely to cause a hyperestrogenic state. And we all know endometriosis is caused by hyperestrogenic state. So if we repeatedly stimulate our patients, there is a possibility of recurrence or aggravation of endometriosis. Secondly, When we are doing ART with ovarian endometrioma, there is an increased risk of puncturing the endometrioma during egg collection, which may result in pelvic infection and pelvic abscess formation. Because of endometriosis, the surrounding structures are adherent with the uterus and ovaries, so there may be inadvertent damage to bladder and intestine during oocyte retrieval, and that may also be responsible for pelvic infection. Now, other thing we have to keep in mind is if we are not doing surgery and straight away going for ART, even if there is a very small risk of ovarian malignancy associated with endometrioma, we are actually ignoring it. So we are, not treating the person well, and maybe after the pregnancy or during the pregnancy, she may present with ovarian malignancy. So these are very rare possibility, but we have to keep in mind. Do we need to prepare our patients before ART? Now, there are papers published suggesting that if we treat our patients with oral contraceptive pill, progestrogens, or GnRH analog for 3 to 6 months, it improves the environmental changes with endometriosis. So the hostile environment, even with mild endometriosis, the hostile environment will be altered, and that would perhaps improve in the embryo implantation. And it has been reported that if we give GnRH analog therapy for 3 to 6 months before ART, then it improves the chances. But we also know that these patients who have had such a long duration of GnRH therapy, they will require a higher dose of gonadotropin. So the cost of therapy is increased. So the new concept is perhaps we can do oocyte collection, fertilize them, store them by vitrification, followed by suppression of ovarian function by gonadotropin for 3 months, and then do FET later. So we are getting the benefit of recruiting good eggs without suppressing with GnRH, and then subsequently the embryos can be transferred when the environment is very good. There are new medical therapies like anastrozole, Dynogest, and cabergoline. So the question is, can we use this medicine for 3 to 6 months before starting an ART? Now, answer is we do not know very well. I've just read a paper recently published last year, which showed the clinical outcome of Dynogest therapy before in vitro fertilization in infertile women with endometriosis. Now, these patients were given in one group, they were given 3 months of Dynogest, and other group were controlled, not any therapy. And it was found that, as a matter of fact, Dynogest had a detrimental effect. Although it improved the endometriosis pain, maybe it diminished the size of the cyst, but the number of follicle, retrieved oocyte, fertilized oocyte, and blastocysts, they are all significantly lower in the Dynogest group. And the pregnancy rate was basically same. There was no significant difference in the implantation rate between the two groups. Cumulative pregnancy and live birth rate was actually lower in the Dynogest group. So this study suggests that Dynogest failed to reduce the inflammatory cytokine levels and oxidative stress in the follicular fluid. So it doesn't give any benefit to infertile patients. Now, I've covered this during my slides on surgery, that whether we should do surgery before ART or not. And I reiterate, the surgical excision of endometriosis does not improve ART outcome as was expected by many of us earlier. It results in loss of ovarian function, loss of ovarian reserve, poor ovarian responsiveness to gonadotropin. So surgery should be better avoided in older patients, asymptomatic patients with low ovarian reserve, bilateral ovarian endometrioma, and I say this again and again, with prior surgical treatment. So those who had prior treatment, no further surgery. So the bottom line is surgery is only limited to younger patients who have pelvic pain and not in any other patients who also are suffering from endometriosis. Endometrioma, not necessarily presence of endometrioma will impair the outcome of ART. Endometrioma causes damage by follicular depletion. It has been suggested there is increased oxidative stress, necrosis of the follicle, and apoptosis of the oocyte in the presence of endometrioma. But the ovarian damage is actually quantitative rather than qualitative. So there are few oocytes of relatively unaffected quality. And we also see the surgical damage to the ovary by removal of healthy ovarian tissue and vascular injury, which I've already mentioned earlier. The quality of the oocyte remains same after the surgery. So it is only because of the access, if the ovarian endometrioma is actually preventing us in egg collection, then only we will go for surgery before ART. Now, this slide summarizes the benefits of endometrioma removal and the limitations of endometrioma removal. Now, the risks of endometrioma removal are, of course, surgical risk. I've told damage to ovarian reserve, premature ovarian failure. There may be incomplete surgery and disease may recur. The surgery depends upon the experience of the operator, and there's a learning curve, and definitely surgery will delay ART. Now let's look at what happens if we leave the ovarian endometrioma and go ahead with ART. Of course, there is accelerated progression of the disease. Disease may progress during ovulation induction because of hyperestrogenic state. The follicular fluid may undergo contamination because of puncture of the endometrioma, possibility of infection. There is increased requirement of GnRH to suppress the ovarian endometrioma. I've mentioned about undiagnosed occult malignancy. There's possibility of chemical peritonitis. There's increased risk of cycle cancellation. And because of the endometrioma, we may have difficulty in collecting the oocytes. So if we have an endometrioma, this is a simple way to decide what which we should do. This algorithm will help us to decide what we should do before IVF. Now, first we ask if there is any previous surgery. If the answer is yes, definitely we are not going to do any further surgery. We can ignore the endometrioma and go ahead with IVF. Or we can give 3 months of GnRH agonist therapy and then go for IVF. If there is no prior history of surgery, then our decision will depend upon the size of the cyst. If the cyst is less than 3 centimeter, definitely no need of surgery or medical therapy. We can straight away go for IVF. If the cyst is between 3 to 5 centimeter, then we give 3 months of GnRH. If the cyst is more than 5 centimeter, then the surgery. But the decision making is not so simple. It will also depend upon patient's age, patient's ovarian reserve, and many other associated confounding factors which will help us to decide. In general, we should avoid surgery or medical therapy if that's possible before ART. Now let's look at what are the outcomes of ART. Now the studies published in before millennium, what we understood is different than what we are understanding in the recent years. Now, it was said in the previous meta-analysis done, published in 2002, the number of oocyte received, implantation rate and pregnancy rate is actually lower in the patients with endometriosis in comparison to those with unexplained infertility or tubal factor. Now, obviously, the success rate with stage 3 and stage 4 is much lower than stage 1 and stage 2. Now, this have been repeated by another study in 2005, where again it said that implantation and pregnancy rate is actually lower in comparison to the other causes of infertility requiring ART. But the recent ESHRE guideline in 2013 and two meta-analysis published in 2013 and 2015 has shown that endometriosis does not adversely affect the pregnancy rate with ART, both in SART as well as HFEA database, that is USA and UK database. This is what we are understanding. Now the question is why? Why endometriosis? Obviously what is happening is now we have better gonadotrophin. Now our embryology lab facilities are much better. We are doing blastocyst transfer. We are freezing the embryos and transferring them in an subsequent cycle where we have a better endometrium, better environment. So all these has put us in a situation where we do not say anymore the patients with endometriosis, ART gives a lower success rate in comparison to that with unexplained infertility or tubal factor infertility. So Our choice, whether we do agonist cycle or antagonist cycle. Now, many people said that agonist cycle is better because it suppresses ovarian function, but statistic shows, the paper published shows there is hardly any difference whether you use agonist or antagonist. Implantation and pregnancy rates are similar. It was initially thought the eggs with endometriotic patients are not of good quality, so they may require routine ICSI for better fertilization, but that has again been opposed, but that has again been refuted by the recent papers saying that there is, in the absence of male factor infertility, there is absolutely no benefit of routine ICSI for these patients. This paper showed what is the effect of endometrioma on the oocyte quality. One group had unoperated ovary with endometrioma. So an ovary had endometrioma. And other ovary, there was intact ovary without endometrioma. So what was found? The fertilization rate is very similar, cleavage rate is very similar, and high quality embryo rate is also very similar. So we are getting this data and asking ourselves, is it worth removing endometrioma before IVF? The answer is not really, unless the patient has a symptom of pain. So for infertility, those who are going for ART, surgery is not required. Now this paper, this is a systemic review and meta-analysis looking at the effect of ovarian endometrioma on ovarian responsiveness. Now this was intra-patient comparison. So same patient who had unilateral endometrioma and another normal ovary. And what was found, that the number of oocyte received, M2 oocyte, total embryo formation, they were all very similar. So presence of endometrioma really didn't affect the outcome of ART. So friends, the take-home message for ART and endometriosis is as follows. Nowadays, even nowadays, in majority of the clinic, ART is indicated as a last resort for infertility patient with minimal and mild endometriosis, because we can treat them with expectant management if they're young. We can give them ovulation induction with clomiphene citrate, letrozole, gonadotropin. We can give them IUI, and if not, then only we will do IVF. Whereas in moderate and severe endometriosis, ART should be opted much earlier because it is much more effective treatment in terms of getting them pregnant. Medical therapy, I've repeatedly said before, and again I'm saying now, medical therapy has almost no role or very limited role before ART. It may be used for ovulation induction, but using the therapy with GnRH or with anastrozole or with Dynogest in order to help, or oral contraceptive pill in order to help, like rebound ovulation, these are of no definite, role. There is no definite role for improving their pregnancy rate. Efficacy of surgery in minimal and mild endometriosis has been confirmed, but it is not mandatory before starting an ART. So if a laparoscopy has been done for any other purpose, diagnostic laparoscopy or laparoscopy for pain, we have treated them fair enough by either by coagulation or by excision or by laser, fair enough, but with or without that surgery, the outcome of ART is not going to be any different. And finally, in moderate to severe endometriosis, the role of surgery in infertility patient is very, very limited, and it may be detrimental in some cases before ART. So, ladies and gentlemen, I've tried to cover different aspects of endometriosis management, keeping in mind the aim of infertility treatment. So if an infertile patient presents and the diagnosis is endometriosis, we can treat them either with ovulation induction, or we can treat them with surgery, we can give them IUI, or we can give them IVF. But my opinion, being a laparoscopic surgeon as well as an ART specialist, my opinion is more tilted towards ART because I am getting better results in my personal experience, and also the published papers are suggesting that we should encourage more and more of our patients to go for ART soon, if they can afford, perhaps make the treatment uh, within their reach, make it the cost effective within their reach so that they can have an effective treatment. But if they're present with pain, then surgery has a definite role. Thank you very much. Thank you. Thank you for your patient hearing. I'll be more than happy to answer your questions.
Yes, Gautam, that was an excellent overview of presentation on subject of endometriosis you covered in less than 1 hour with wonderful take-home messages. Tushar, can I have some slides, please? Tushar? Gautam, I'm just going to present something about ISAR, just
Yes,
6 slides, and then after that we'll go to your question answers.
sure.
So, next slide, please. So, this is one of the activity that ISAR is doing, known as Dr. Sadhna Desai's Endowment Fund, which is used for giving a fixed amount of money to an eligible couple requiring IVF-XC treatment, which is from a donation given by Dr. Sadhna Desai. Next slide. So the rupees of 50,000 would be paid to the eligible couple who is undergoing of IVF in India, but this has to be initiated by the person who is treating it. It cannot be initiated by the patient itself. So all of us should know that you can go to the ISAR website and initiate this particular thing. Next slide, please. This is about our journal, Journal of Human Reproduction, and which deals with the topics of andrology, assisted conception, endocrinology, and fertility-related surgery, pre-implantation genetic diagnosis. Next slide. Madhuri Patil is the present chief editor. And next slide, please. Padmareka Jirge and Mohan Kamat are the associate editors. And why we should publish in JHRS? We have a very good impact factor now. We have 40% of overseas publication and we have indexed in a very good journals. The next slide, please. The third and most last thing is how to have an ISAR virtual accreditation. Now, there is no need of real-time audit. It's a virtual audit where we can do a counseling session by Skype or Zoom, and it's valid for 3 years. And next slide, please. And these are our team members who are in each zone. You can contact them and they will help you to get your center ISAR accredited, which will help you to participate in ISAR teaching activities in coming years. With this, I will come back to Gautam for some questions. So this is from Dr. Deb Shankar. In case of severe endometriosis, is there any role of prophylactic tubal ligation?
I mean,
Hello?
I think, yeah, I
Yeah.
think the question comes with this idea that retrograde menstrual flow is one of the etiology of
Hmm.
endometriosis. So by
Hmm.
doing bilateral tubal ligation, perhaps
Hmm.
we can
Hmm.
prevent retrograde menstrual flow. But I don't
Hmm.
think there is much logic in it because there is already severe endometriosis. So I mean,
Hmm.
if that patient is undergoing ART, if
Hmm.
that patient is undergoing ART and there is hydrosalpinx, then we will
Hmm.
do tubal clipping to prevent
Absolutely.
hydrosalpinx fluid coming inside the uterine cavity, but not
Hmm.
routinely with normal fallopian tube. Just bilateral tubal ligation, I don't think is going to help in either way with infertility or pain relief.
Okay. There's a question from me to you. In relation to the endometrioma, would you always do an excision or fulguration? What is your take on that?
Now, basically, from my experience, what I see, if it is a small endometrioma, often it is very difficult to enucleate the cyst. So what we can do like marsupialization. So if the
Okay.
cyst wall is excised on the top, and you enter the cyst cavity, and
Okay.
fulguration of the cyst wall, fulguration of the cyst wall, that can be, that will be effective. But for a large endometrioma, if you do that, the chance of recurrence is much higher. So in that case, cystectomy is much better. So what we do, we try to develop a plane
Okay.
between the cyst and the remaining ovary and try to
Yes.
excise the cyst. And as we go close to the hilum, we find
Mhm.
that portion of the cyst is very difficult to remove. So we excise
Correct.
the already, which has been dissected, and that portion of cyst which is close to the hilum, it is fulgurated. So the amount of remaining cyst wall is very small.
Okay. Now, how do you dissect this plate? Do you inject vasopressin?
Well, I mean, personally,
Vasopressin, or do you inject
I've found
saline
by
into
injecting,
the?
yeah, some patients some doctors have done it, injecting vasopressin, but I find that if you make an incision on the cyst wall, on the cyst, on the ovary, uh, sometime even without injecting, the plane can be developed. Or other way is to make an incision, drain the cyst. When the cyst collapses, then it is easy to separate the cyst wall from the remaining ovarian tissue. So when the cyst is very tense, it is sometimes difficult to develop a plane, but when the cyst collapses, then it is much easier to develop the plane between ovary and the cyst wall.
Just a minute. I think there is some internet issues with Dr. Ganla.
Okay.
Just a minute, sir. Dr. Ganla will be joining us again.
Sure.
Sir, I'm sending some questions.
Yeah, I can
Chat on.
read it. What is your opinion regarding endometriosis with adenomyosis? Yeah, I mean, adenomyosis is a problem which is very difficult to treat. Now, of course, with adenomyosis, the chance of embryo implantation is less. People have tried GnRH analog, or Mirena, levonorgestrel, intrauterine system for the treatment of adenomyosis. If the adenomyosis is localized and if it is very large, many people have operated on adenomyosis and then gone for treatment. So if it's a small adenomyosis, if it is a diffuse adenomyosis, no role of surgery. We may give them GnRH analog for 3 to 6 months. Putting a Mirena for 3 to 6 months is not cost effective, but people have tried it, and there is no published paper suggesting that it's really effective in terms of infertility. So the opinion is still not very clear. Now, the next question, endometriosis correlated with infertility is a serious problem. What could be your suggestion as a part of, I mean, this is what we have been discussing. The endometriosis with infertility is a serious problem. Now, if the patient has pain with infertility, then sometimes the pain is so severe that we have to treat the pain first. Now, treating the pain with medical therapy actually suppresses the chance of pregnancy. So we can treat medically for 3 to 6 months and then start on some infertility treatment, or sometimes we do surgery, which gives instantaneous pain relief, and then perhaps we can go ahead with infertility treatment, be it ovulation induction or be it ART. Uh, the next question is by Dr. Radha. Uh, okay. Now, immediately after surgery, now many people have said that after surgery, we used to give them some medical therapy to prevent the recurrence. So before, after endometriosis surgery, we used to treat by another GnRH analog or sometime oral contraceptive pill for 3 to 6 months before trying for surgery. But the current opinion is we should not waste our time. So immediately after surgery, as I've shown in my presentation, the first 1 year is most effective. So immediately after surgery, perhaps they take 1 month from recovery. So following that, they may try on their own, like for 3 months, with ovulation induction only, be it clomiphene or letrozole. And if they are not pregnant in 6 months' time, then ovulation induction with gonadotropin would be the right choice. Now, that is again the next question by Dr. Anvita, who says ovulation induction drug for endometriosis. I've covered in my talk, clomiphene citrate is the drug of choice from ages, but now letrozole is taking its place. With letrozole, we develop either 1 or 2 follicles, not so many follicles with clomiphene, or we go with gonadotropin. Now, in my view, if the endometriosis is mild and if you have done a good surgery, you can give them 3 to 6 months with ovulation inducing medicines, with tablets, and then go for gonadotropin with
Okay,
follicular
Gautam,
monitoring.
I'm back now. Gautam,
Yeah,
would you be able to explain the viewers that what is about embryo pooling, embryo freezing, and embryo pooling in a patient of endometriosis with low ovarian reserve? What are we nowadays in ART doing to increase the success rate?
yeah.
I want you to summarize the whole thing.
Yeah, basically, if the if the ovarian reserve is less, when we are stimulating them, perhaps we are getting 3, 4, 5x. Now we can stimulate them immediately in the same cycle or in the subsequent cycle, and we are fertilizing. We are fertilizing the eggs what we are collecting, and we are storing the embryos. So when we have good number of embryos, then we can transfer them. Because what happens is you have tried a cycle, the patient didn't conceive, and then she's waiting for another 3 months. So by the time her age is increasing, her ovarian reserve is diminishing. So while she is still having good number of eggs, you harvest as many eggs as possible. You
Excellent.
fertilize them. She may want to
Excellent.
come back for a second child. And
Okay.
nowadays, what we do
So,
blastocyst transfer. So that is the whole
yeah.
idea. Collect as much as possible. And many patients, young patients with endometriosis, are coming to us,
Yes.
or not so
Yes.
young but still unmarried. They are coming for
Hmm.
oocyte retrieval and oocyte
Hmm.
freezing, because they know it very
Yes.
well that by the time they are married, their ovarian reserve will be farther down the line. So this is one of the
Okay.
indications of oocyte freezing. Oocyte
Hmm.
freezing. But for married individual or someone with partner, embryo harvesting or embryo pooling is much better because it has got a better success rate.
Okay. Another question of mine is if you have a young girl, say of 18, 20-year old with stage 4 endometriosis, okay, or stage 3 or stage 4 endometriosis, done a surgery, and now she doesn't have a plan to get married, but the parent wants to prevent the recurrence of endometriosis. So, what sort of treatment would you recommend them?
Now, in terms of recurrence of endometriosis, we can give them some form of medical therapy. Now, all the medical therapy we have been talking about are very effective in preventing recurrence. We can give GnRH analog, which cannot be given several times because of the osteoporosis, hypoestrogenic effect. So we can give them 1 or 2, maybe for 6 months. That's not my favorite. Majority for the young individual, I either put them on oral contraceptive pill back to back.
Excellent.
So back to
Excellent.
back, like 4 packets of OC pill, 84 days of OC pill, then 7 days gap.
Okay.
84 days, 7 days. This is called cyclical OC pill therapy. But
Okay.
now I'm also using Dynogest a lot, and it is
Okay.
giving good result. It is giving
Okay.
good result because I, I've seen a patient only today whom we prescribed ocipil following endometriosis, and she developed deep vein thrombosis like symptoms. So
Okay.
ocipil has its side effects, although it's rare. So we shifted her to Dynogest. We can also
Okay.
use anastrozole, which has side effects of hypoestrogenic. So these are the different therapies which can prevent recurrence of endometriosis.
Is there any time lag when you start Dynogest and the effect to come? So what I mean to say is you operated stage 3, stage 4 endometriosis. Would you give them a Lupride depot, say 1 or 2 cycles, and simultaneously start Dynogest, and
Yeah,
later date you continue Dynogest so that
yeah.
the recurrence rate would not happen? So what is your
Yeah,
opinion?
this is very helpful, very appropriately you said, because when you start Dynogest, some of the patients have irregular bleeding, breakthrough bleeding, and because of that irregular periods, they are often very unhappy. If you put them on GnRH analog, this side effect diminishes, or the side effect is very absent. And it is also very helpful because Dynogest takes little time to work, maybe 3 months to work. So by that time, GnRH analog is going to work straight away. So immediately after surgery, they have one shot of 11.25 milligram, and then 3 months later, another shot, and they start Dynogest at the same time. 2 milligram of
Okay.
Dynogest, in my opinion, is fine. Very rarely 4 milligram is required.
Okay, that depends upon the weight of the patient or depends upon the severity of the disease, or how do you decide the dose, 2 versus 4,
Well,
or
basically
the
the weight
control
of
of
the,
symptoms?
I mean, the weight. In my understanding, the majority of the patients would benefit with 2 milligram. But if there is a,
Yes.
if the body weight is higher, then perhaps we have to use 4. Nothing to do with
Higher.
the severity. Yeah.
Okay. Now there are typical questions of this. When hydrosalpines, would you do a tubal ligation or hysteroscopic osteal coagulation? And will
Yeah.
it have an impact that hysteroscopic coagulation would have impact on endometrial receptivity? So I think you can talk on it. There's no problem. Yeah, go ahead.
Well, basically, I'm not an expert on this. I mean, I haven't done endometrial, hysteroscopic
Hysteroscopic,
cornual
yeah.
thing, coagulation. I do not have the expertise. I do not have experience, so I cannot comment on that. But
Correct.
in my opinion, laparoscopic procedure is quite simple. Although it's a little bit more invasive, they need a laparoscopy. It's a invasive. But even after that, there is a possibility of cornual ectopic. There's a
Okay.
possibility of cornual ectopic.
Absolutely.
So we have to keep that in mind. But it
Okay.
is true that hydrosalpinx requires some form of intervention to improve
Okay.
the
Now,
implantation rate.
does stage 3, stage 4 endometriosis or endometriosis per se, does it have an increased rate of miscarriages?
Uh,
And if
you know,
yes, how do you prevent it? Means, how do you prevent it?
I think if we say that the advanced endometriosis will affect the quality of the egg, that's one way, uh, because of oxidative stress, or because of the phagos, the interleukins and other things. If the
I
environmental
think so.
factor has detrimental effect on the egg quality, so poor egg quality resulting in poor embryo, resulting in miscarriage. That's one theory. But
One
I've
theory.
mentioned
Talk.
in my talk that the quality of the embryo are not quality of the egg is not different. Quality of the egg is not different. So in my view, it is most likely the endometrium which is responsible, or maybe the corpus luteal. So in my talk, I've shown one slide that the rate of miscarriage is higher in endometriosis, possibly because of its effect on the endometrium rather than on the egg. Now, we can say this much confidently now because all the recent papers are showing the the number of embryos, the quality of the embryos, and the success rate, implantation rate are same whether they have endometriosis or something else. And there is a view that we save these embryos and not transfer fresh. We give them 6 cycles of GnRH analog or any other medical therapy, change the environment, and then transfer, perhaps in an HRT cycle or in a natural cycle. So in order to reduce the miscarriage rate, we have to address the endometrium more than the embryo.
So,
That's my view. But
yeah,
sorry,
no, 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 it's
but there will be
absolutely fine.
patients where the
Absolutely
ovarian
fine.
function is so poor, that you are not getting good quality eggs at all. In some severe endometriosis, we have done donor egg program. We have used donor oocyte, and
So
the success rate.
my, my next question is, say
Yeah,
if you have an occasion patient of endometriosis, but the oocyte quality, embryo quality has been good, 2 to 3 failures. Now, would you do something in down regulation to ablate or reduce the effect of endometriosis completely in the third cycle or a fourth cycle? Will you do it if you are given opportunity to do a research on this subject? Would you do that?
you mean this therapy before egg collection?
No, no,
Before
no.
egg
Before
collection?
the FET, before FET. So you've
Yeah,
done the
of
embryo
course,
pooling.
yeah,
Yeah, yeah. So
yeah,
what?
yeah.
What
That
kind of?
is what everybody is talking now. That is the talk of the day. That is the
Yeah.
talk of the day. Because of our facilities of vitrification, we can
Hmm.
preserve our embryos for several years together. So
Hmm.
let's collect the eggs, let's
Hmm.
create the embryos, and keep
Hmm.
them until the
Hmm.
endometriosis is cleared from the pelvis.
Hmm.
And this question of surgery affecting the ovarian reserve and ovarian quality. If you have harvested enough eggs, someone
Hmm.
suffering from severe endometriosis, severe pain,
Hmm.
advanced endometriosis, after egg collection, we can do
Hmm.
a surgery. We can do a surgery, or we can give medical therapy, create a
Absolutely.
better environment, and then
Ah,
only transfer the embryos. So
I think
this,
it's
some form of
very,
research should be done.
very nice. I think there are 2, 3 people who are talking about the role of your opinion in case of severe endometriosis and frozen pelvis. How do you do diagnostic laparoscopy, kind of a thing? So, what would you advise them about this?
In my opinion, if you find frozen pelvis and if the problem is infertility, you should
Mhm.
just come out. What is
Okay.
the point exploring that? If she
Okay.
suffers from pelvic pain,
Understood.
then of course surgery is required, and it has to be dealt with someone who has extensive experience, in advanced laparoscopic surgery, and not by any general fertility specialist who is just doing a diagnostic laparoscopy.
Absolutely.
So that
So,
is my view. It's better to do less. It's better to do less rather than
hmm,
more, keeping infertility in mind. Now, when
okay.
the pain is the problem, after completing the family, you can remove
Hmm.
everything. You can remove the ovary, uterus, everything, and give them a
Pelvic
permanent relief.
clearance.
Yeah,
Yeah. So there is one doctor who's asking, I think Dr. Chopra, how long these eggs can be stored without any deterioration in the quality. I think eggs in the sense you can talk both
yeah.
oocyte and embryo. Your
In
opinion.
my opinion, the 5 years is definitely 5 years is definitely a time limit which can say with confidence. Now, we do not have any law in our country, but
Hmm.
in those countries where there is law like HFEA, they say again 5 years. Now, there have
Hmm.
been reports and there have been experience from my personal side that
Hmm.
recently we had a patient who
Hmm.
came back to us after 6 years, and
Oh.
they told, after 6 years of having a child, and they wanted to have the embryos back, and we explained to them the detrimental effect of freezing. For example, they said we want to have it a go, and believe
Hmm.
it or not, they had a lovely set of twins. A
Wow.
lovely set of twins. So single baby on the first go, and two more babies from the same set of embryos. But to answer our doctor who asked, I will say 5 years. We encourage the patients to come back within 5 years.
Okay, now a question from my side. In whatever the guidelines say is different story. We know that the Indian women have lesser ovarian reserve as compared to Caucasian population,
Right.
and if they have an endometriosis and stage 1, stage 2 endometriosis, actually, how long or how many trials of IUI you will really give in your private practice? considering the two aspects. One is the good AMH young patient, second not so good AMH little older patient.
Yeah.
How many
I mean,
cycles of IUI would you try?
young patient, good AMH, I would do maximum 3 to 4 cycles.
And that
Maximum.
would be HMG IUI.
HMG IUI. HMG
Excellent.
IUI.
Excellent.
I do not do IUI with clomiphene or letrozole.
Thank
It's
you very
I
much,
think
doctor.
when you are giving a time, I think
Ah,
when you are giving a chance, you should do the best. You
right,
should do the
right.
best.
Very good take home
And
message.
this has been my belief. And I just
Hmm.
wanted to add this. When I started my practice 20 years back in Kolkata, uh, people were surprised that perhaps I was the only doctor at that stage in Kolkata who was using 100% gonadotropin for IUI patients. Now, what happens in India? Majority of us are concerned about the cost. But what we have to remember is not the cost, it's the cost effectiveness. It is the cost effectiveness. Your patients are happy to spend the money if you give them results. So all IUI should be gonadotropin IUI, in my opinion. And HMG is good enough. Urinary FSH, urinary HMG is good enough for these patients. But if it is an elderly patient, as you said, with poor ovarian reserve, I would rather convince them to go for IVF straight away rather than spending time with IUI. But if they are not able to do it, then perhaps again 3 cycles would be maximum IUI we
Happening.
would do.
Doctor, I'll post the question in the chat.
Right. Now we have put some MCQs. We have put some MCQs. I think we have put 3 MCQs covering the topic of today's lecture. And I'm sure they will be put on the post. And we would like to know your opinion on today's lecture. Thank you.
So there's one more question coming in.
Right, let's see. Yes. Yeah, we have covered this question. We have covered this question. I
Hello.
mentioned that I don't have much experience on hysteroscopic osteocoagulation, and there is a possibility of
There
damage to endometrial receptivity. So I do laparoscopic tubal
is
ligation.
There are some issues with Dr. Ganla's internet connection, sir.
Right. So you can give us if there is more question.
Sir, I'm posting the question in the chat.
Yeah. Definitely, danazole is not the drug of choice of anymore because danazole has lots of side effects. Danazole has lots of side effects. Long-term danazole use is not possible because of its adverse effect on liver, its adverse effect on like adverse side effects like hirsutism, voice change, etc. So danazole has gone to the history book as regards endometriosis treatment. I would rather use the Dynogest, the progesterone. I can use anastrozole. I can use GnRH analog. GnRH analog. People are suggesting that perhaps in future we will have oral antagonist, which will be very helpful. Some people have used cabergoline because also it causes hypoestrogenic. Uh, so to answer your question, danazole is absolute no. We can use other medical therapy to prevent recurrence of endometriosis. And in my belief, what I say is if patient has endometriosis, she should stay in the follow-up until the age of menopause and maybe even 5 years after the menopause. There is nothing like cure with endometriosis. Endometriosis can recur. And those patients who have had surgery under my care didn't come back, didn't maintain any follow up. Many of them had recurrence. But those whom I've seen every 6 months, put them on medical therapy, follow up ultrasound, the recurrence rate is almost less than 5%. But if they do not take medical therapy, they do not have follow up, the recurrence rate may be as high as 20 to 30% following a good laparoscopic surgery. And following medical therapy, the recurrence rate is as high as 50%. Letrozole for 5 days, then okay. Now this question of using letrozole and then giving HMG has been suggested by many fertility specialists, but that is not my preference. As I was talking with Dr. Ganla, that when I use letrozole, I use just letrozole. When I use clomiphene, just clomiphene. I do not combine. But I believe that if you are doing IUI, you should use just gonadotropin. You should use just gonadotropin. And uh, this question of using HMG on alternate days, or I mean, the half life of HMG is 24 hours. The action is for 24 hours. So how can you use HMG on day 3, day 5, day 7, day 9? So you can say there's a background gonadotropin in the system, but if you're giving HMG, you should give it every day. You should give it every day. Now, in India, what happens is we always have this bug in our brain saying cost, 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 keep cost low, keep cost low. So that is why we combine. That is why we combine to keep the cost low. But endometriosis patients need proper dose. So if you're doing an IUI, please use HMG from day 2 or day 3 for 5 days, and then see what is the response on day 7 or 8, and then give them for another 3 days or 5 days, and continue like that until your dominant follicle is 17 or 18 millimeter. And then you use ACG and do a timed intercourse or do an IUI. Now, continuous Dynogest can be given easily for 6 months. Now, people have used it even longer than that without side effect, and that is one of the great benefit of Dynogest, that it doesn't have much side effect. To start with, some patients present with irregular bleeding spotting, which can be controlled by giving GnRH analog for 1 or 2 GnRH analog. But otherwise, it is a very safe drug and can be continued for a long period.
So that's all with the questions, sir. I'll
Okay.
request you for a short takeaway message for the doctors.
Well, my message for the fertility specialist looking at the endometriosis patient is, this is a very sensitive group of women who are very unfortunate. Many of them are young, they are otherwise very healthy, but they have this dreadful disease. I say dreadful because it has been compared with cancer. It is like the disease will continue, and some of them suffer from intractable pain which requires hysterectomy, and it affects their fertility. So we need to treat them very sensitively. And we should offer them the best possible treatment at a very early stage. Instead of delaying, instead of going slow, we should do active management of infertility, like active management of labor. I was taught this by my teacher in UK, that active management of infertility is completing the whole infertility treatment within 18 months. So first 6 months ovulation induction with medicine, next 6 months ovulation induction with gonadotropin, with or without IUI, and the last 6 months is IVF. Now, many people cannot afford the treatment, but we should offer them, because many patients have come to me and said, alas, if I had known this earlier, I would have gone for the better treatment. Now, the role of surgery in endometriosis is very much limited to pain, endometriosis with pain. And the role of surgery and the role of medicine is also for pain, except ovulation induction medicine. So for infertility and endometriosis, we should treat them initially with ovulation induction by letrozole and clomiphene, maximum 6 months. Then you give gonadotropin injection with IUI for 6 months. And if they are not pregnant within a year, go ahead with ART. So in my opinion, if a patient can afford, they should have ART much earlier than other causes of infertility. Thank you. Thank you for listening and watching.